There's the treatment of acute gout, and there's the treatment of chronic gout. So the first thing I have to tell you is what you need to know for the board exam, and that is acute gout is treated with Nsaids. Not indomethacin, not Motrin, any NSAID. No NSAID is proven to be any better or any worse than any other NSAID. Nowhere in history can you find this, no literature can tell you this. So when you see indomethacin being used all over the place, this is a knee-jerk reaction by people that are not well informed. It's actually more dangerous to use indomethacin. It is a more harsh NSAID, similar to one of the NSAIDs that 20, 30 years ago was taken off the market in Mexico. Can't think of the name, but indomethacin followed it, and it cut the mustard, and it stayed on the FDA formulary. But anyway, suffice to say, NSAID is the treatment of acute gout for the board exam. Okay, but we're not the board exam. We're going to treat patients. So when someone comes to my office with a hot joint, I'm going to drain the joint, and if I see crystals or if they're a known gout patient and I don't suspect an infection, I'm going to inject the joint with steroids. If I see somebody in the hospital who has multiple joints and they're a gout patient, and I've proven to myself by clinical exam, blood work and such that I don't believe they're infected, IV steroids every time. 1 or 2 doses of Solumedrol is going to do a lot better than any amount of Colchicine or any amount of Nsaids. And frankly, it's safer. You can't tell me too many side effects from 1 or 2 doses of Solumedrol. I don't care what the dose is. We give 1,000 milligrams of Solumedrol empirically to almost every sick lupus patient with no side effects. So I can't imagine 125 milligrams of Solumedrol being a problem to any hospitalized patient, even if they're a brittle diabetic, because they're being covered with insulin anyway. NSAIDs, on the other hand, including Toradol, cause GI bleeds. NSAIDs cause hypertension. NSAIDs cause fluid retention. NSAIDs cause renal insufficiency. High-dose acute use of steroids causes hyperglycemia. That's it. End of story. Colchicine is extremely toxic. Using colchicine, as far as I'm concerned, shouldn't happen in gout. There's really no reason, there's never a situation that I can possibly think of that a person needs to use colchicine in the treatment of gout. Not acute, not chronic. Once you give a person a loading dose of colchicine, they can't have it again for a week. Second, patients with mild renal insufficiency, which are often the gout patients, who are on chronic, quote-unquote, normal doses of colchicine, 0.6 once or twice a day, develop, and this is a board question too, they develop the colchicine neuromyopathy. I've seen this about 8 times since I've been on the faculty here. So in 21 years, I've seen 8. Granted, that's not a lot, but I'm sure there's another 15 that I wasn't called on. So I don't use colchicine. I use colchicine occasionally in treating somebody who has calcium pyrophosphate arthropathy, which is pseudo-gout or pseudo-RA. But in pseudo-RA, you may actually use methotrexate. So I will not use colchicine to treat gout unless, I don't know, unless there's some very bizarre situation that I cannot think of right now. Because I still can't think of a reason when I can never use a one-time high dose of steroid or a joint injection. And if you tell me there's 12 joints involved, I have injected 12 joints or even more in the past without hurting the patient. But that's with experience, and I would not expect you guys to do that. But I would expect you guys to give one dose of IV steroids. So that's the acute treatment of gout. The treatment of chronic gout, the safest and best treatment is probenecid. Bar none, this is the best treatment. Of course, you're looking to be perplexed because you're only used to xylitrim or allopurinol. Probenecid has almost no side effects. So what are the downfalls of probenecid? The downfalls are, if a person has renal insufficiency, well, first of all, the way probenecid works is by increasing secretion of urate through the tubules. So if somebody has renal insufficiency, then this drug doesn't work. The second thing is if someone has tophus, and we believe most gout is tophaceous gout, you're going to shove salt through these tubules, so you're going to cause renal failure. So therefore, probenecid is not quite that usable, but it's a great drug. And you can combine it, by the way, with allopurinol or Uloric. Okay, so now what do we really use for gout? Chronic gout. Your typical guy who drinks beer on weekends, who has a uric acid of 8.5, who has chronic gout. So chronic gout, what does that mean to me? It means he looks like he has rheumatoid arthritis. He has swelling in his PIPs, he has swelling in his MCPs. And I have pictures along the way. We'll have a lot of pictures at the end. We can talk about some more. So we have this guy who looks like he has rheumatoid arthritis, but in fact it's proven that he has tophaceous gout. The way to treat this person is with allopurinol. So you give the guy allopurinol, he's going to start at a low dose, and you're supposed to titrate this dose up. The way I'll do it as a rheumatologist with my confidence and my experience is going to be different than you're supposed to do it. You're supposed to start at 50 or 100 milligrams, depending on their creatinine clearance, and build the dose up gradually until you titrate the uric acid to under 6. 6 is the absolute minimum. 6 is better than 7, but 5 is better than 6. So if you can't get them to 6, we do have other things that you can do. And by the way, Uloric is not a drug you should ever use either, except if the person is allergic to allopurinol. Okay, so why is this allopurinol allergy so important? Well, one, it's a board question. There's a small percentage of people from taking allopurinol that will develop a life-threatening vasculitic rash. It's called an allopurinol hypersensitivity reaction. I've seen it on the room boards, and repeating the room boards 2 times, and I've seen it on the internal medicine boards, and repeating the internal medicine boards. So this topic, both for colchicine and allopurinol, those questions are always asked. So, you need to look for eosinophilia and thrombocytopenia, or a rash, in an allopurinol patient, and you stop the drug. Unless it's a minor rash, and you want to be gutsy, you have to stop the drug. So if you have to stop allopurinol, you need to lower the uric acid. We used to use oxypurinol, which is the metabolite of allopurinol. Allopurinol's peed out of the body in an hour or 2. Oxypurinol's half-life is 12 hours. Oxypurinol does all the work. There are some of us rheumatologists in the country who can still obtain oxypurinol, but we don't. We use Uloric. The other alternative, which you should at least know about or hear about, is that we used to desensitize people that are allergic by giving them microscopic doses, having diluted by the pharmacy down to micrograms of allopurinol. But anyway, today, if a person is allergic to allopurinol, we put them on Uloric, febuxostat. The problem with febuxostat is that once you go past 120 milligrams, it's no better than 120 milligrams. So your starting dose is 40, you go to 80, you go to 120. After 120, the uric acid is often still not controlled, and then you're stuck. With allopurinol, even though you think the only doses are 100 and 300, the average person is taking 400 to 600 milligrams of allopurinol. And I didn't mention that before, but that's why none of your patients that you see are being treated properly, because they're not getting enough allopurinol. So before worrying and before adding this or adding that, just remember that you're probably under-treating the patient. As long as they're not getting a side effect, you have to increase the drug. And when you make dose adjustments, again, you're taking the body out of its steady state, and by taking the body out of steady state, you run the risk of an attack that you need to prepare for, either with some low-dose steroids, or in some people's case, colchicine, or Nsaids. But I would stay away from colchicine under every possible circumstance. I don't even think it should really be on the formulary of any hospital. Unless you're in a clinic where they have familial Mediterranean fever, in which case that's the treatment to prevent flares of familial Mediterranean fever and amyloidosis. Okay, Cristexa. Anyone hear of Cristexa, pegloticase? Okay, the drug's been available for about 2 years. It's a uricase inhibitor. It completely destroys and gets rid of all the uric acid in the body very quickly. It's given IV every 2 weeks, and it immediately drops the uric acid to 0. Anything that doesn't drop the uric acid to 0, let me speak proper English. If you don't drop the uric acid to 0, if you drop it to 5, or if it doesn't go down, that's considered a failure, and that person is at very high risk of getting a life-threatening reaction, so you don't give it to them again. The drug comes in a pegylated form, specifically because the PEG, or polyethylene glycol, protects the molecule and makes it has less immunogenicity, and therefore less chance of this life-threatening reaction. So we have to be very careful when we give it. We have to select very carefully who we give it to. Another thing about gout that I think it's important that you should know, a lot of these patients with renal insufficiency or renal failure, they end up going on dialysis. Urate is dialyzable. So in fact, dialysis is a good treatment for gout. Right, you all knew that, of course. Okay, good. Okay, so this picture, so now we're going to go through pictures, and I'll probably repeat a lot of what I said. This is what would be referred to as podagra. This is a red-hot swollen first MTP, or metatarsal phalangeal joint. And there's an article written in the 1970s that says, or the title is, Podagra is more than gout. And there were about 20 things listed in the article that cause podagra other than gout. So yes, this is probably gout, and it usually will be gout, but if you walk into this blindly and think it's gout every time, it may not be. So you should at least be aware that not all podagra is gout. That being said, this is how gout presents in men most commonly. This person, I think this is more shadow, but people with gout do get Achilles tendonitis or even a cellulitic appearance if that's what this happens to be back there. But the whole ankle looks swollen to me here. I can't make out any landmarks. This here is a great x-ray of a person who has destructive disease. You can see, well, the first thing that I see here is all this white stuff. This is all an amorphous soft tissue deposit compatible with tophus. So when you see this amorphous white deposit, along with these holes or erosions, a little erosion there, holes here, a little rat bite here, so-called rat bite erosion, fusion of the joint, a large chunk of bone missing here, lysis of this joint. This is classic of tophaceous gout. You have almost all the features you need to put together this diagnosis by looking at this. So, gee, can this be rheumatoid arthritis? Well, how would you explain this white stuff? So the answer is no. Is this a symmetric, or, well, we don't have the other joint, but if this is only this joint, is this symmetric? No. Do you get these large bone cysts in RA? No. You can see this type of pattern in sarcoid, and you can see this in sarcoid, but in sarcoid you're not going to see the amorphous deposit, which is tophus. Probably the biggest mimic of this, other than psoriatic arthritis, might be sarcoid because of the arthritic and osseous involvement of sarcoid. This here is an olecranon bursa. Everyone can see that the olecranon sac is hanging down. It's filled with fluid. This is a gout patient. If you were to aspirate the fluid, you look at it under polarized microscopy, you'd see gout crystals. I would inject this with steroids. You should give the person Nsaids. After it's drained, you wrap it up with an ACE bandage. You let it heal for 5 days or so. Everything should be fine. I will say one thing. Olecranon bursas get infected very frequently. So if there's a white blood count in synovial fluid of 1,000, nobody thinks of it as infected. Most people will think of it as bland fluid. But a cell count of 1,000 in an olecranon bursa is infected until proven otherwise, even in a known gout patient. This person looks like they have rheumatoid arthritis, but they have chronic MCP synovitis. They don't have wrist swelling, they don't have a proud ulna, they don't have much in the way of deviation of the wrist, and this person has chronic tophaceous gout. This slide actually, well, is it's actually part of a rheumatoid arthritis lecture, because these are what's called rice bodies, and rice bodies are seen in chronic bursa effusions or chronic effusions, but they're not necessarily associated with tophaceous gout. So this slide kind of made it here by mistake, but in one way, you can at least know what tophus doesn't look like. Here's a little tophus on the helix of the ear. It's been felt that because of temperature changes and exposure to the elements, that the ears are a good site for these things to develop, because the tophi are supposed to be happier in the cold weather. This is the typical woman who has diuretic use, postmenopausal, low-dose aspirin, and you can see the visible tophus as opposed to the crystals, which are not visible, which some of us believe are all tophus anyway. This is a more profound case of tophaceous gout in a postmenopausal woman. She has some oozing tophus. The white stuff is the tophus. The yellow is dried up. Perhaps it had some serosanguinous fluid. Same thing over here. Sadly, this is not that uncommon. This is actually quite common. Even this profound is common. I see this all the time, probably every week. So if this person were to follow directions, and if they could tolerate allopurinol, within 6 months this would go away. And if this person couldn't tolerate allopurinol and they had to go on Krystexxa, in 3 to 6 months this would go away. So there's no way that this stuff can't be treated really, but most of the time it's either the patient is not following directions or something's going wrong other than, I mean, this diagnosis isn't missed, but it just doesn't get done. This might be the same person, but oops. This might be the same person again. This is, I'll use this slide to make a point about something. These almost look like they were cut open. And the point I want to make is that a surgeon should never be cutting off tophus because they don't heal. So there's two things about tophus. Usually they're sterile and they don't get infected. And the other thing is that you do not remove them because they're just not going to heal. Podiatrists and orthopedic surgeons like to cut everything off, but the rheumatology consults are lacking, and therefore we don't get to tell them not to cut it off. This is a publication from 2011 that I published from here in my office, and this is tophaceous gout, milky tophus material that I drained from this artificial knee, and it's published in the November issue of the 2011 Journal of Clinical Rheumatology. Okay, end of slideshow. Any questions about gout? Yes?
Patient comes with a history of gout, and let's say we do have to give them diuretics.
Mm-hmm.
How do we handle that to watch for if they have any reaction, acute attack or something like that? Should we prophylactically do something, or just...
Well, this person who has the history of gout, do they come in taking gout medications?
It would be, yeah.
Okay, so they're coming in taking allopurinol 100 or 300, and maybe they're on colchicine.
Yeah.
And they have to go on diuretics, and do they have mild renal insufficiency?
Let's say they don't, yeah.
Okay. They do or don't?
No, I'm just making up a case.
Yeah, no, so I just want to know for specifics of how
let's
that's
say
the
they
question.
don't have that problem.
Okay, so I would just keep them on their medications and go along with your medical treatment and watch them. If they get an attack, you would treat the attack.
Okay.
You never alter the dose of the urate lowering drug under any circumstance because that'll precipitate an attack. So somebody comes in, no matter what's wrong with them, unless they're having an allergy to allopurinol, you don't increase or decrease or stop the drug.
What about if I did have a patient who came in with colchicine, and you said that they should be on colchicine. Should we do a consult with you guys to change the medication or suggest that they see the rheumatologist afterwards? Or...
Okay, two ways to answer your question. If there's a patient who's young and healthy and they're on colchicine for a long time and they're doing well with the colchicine, you can make an argument that, things are well, why should I change it? The first thing I would do in that patient is, one, I'd confirm how their diagnosis of gout was actually made, because in fact they may not have gout. But let's assume they do have gout. If they have gout, then look and see what is their uric acid. If the uric acid is over 6, then they're not adequately being treated anyway. Colchicine can't lower anyone's uric acid, so there's no reason to be using it. It's not helping their disease process. I mean, the colchicine and the NSAID for that person are interchangeable. They're just something to help blunt inflammation. The one thing that I didn't mention is that it's become known in the past year that the actual inflammatory cascade with MSU is interleukin-1 beta. And the drugs like Kineret and canakinumab, these drugs block interleukin-1 beta. Okay, so some people say, we should be using these drugs for acute gout attacks. I think that's absurd to use a $3,000 drug for a gout attack when you can inject the joint or use IV steroids. For the same reason, I think it's absurd to use colchicine in a patient who needs the uric acid lowered. And there's no reason to use both unless they're a very severe tovaceous gout patient. And the reason you're going to use the second drug is because as you dissolve the tophus and it passes through the body to get peed out, it's going to become recognized everywhere it goes, and it's going to be attacked by white blood cells, precipitating an attack. And that's the reason for prophylaxis. But prophylaxis does not need to be with colchicine. There's no rhyme or reason why colchicine is used. It's just used. Just like with NSAIDs, there's no rhyme or reason why anyone's using Indocin all the time. It's the most toxic of the NSAIDs, followed probably by Voltaren, because Voltaren is notorious to be the most hepatotoxic NSAID. There's nothing wrong with a little Aleve, or Naproxen, or ibuprofen. But again, it is much safer to go with a very small amount of chronic low-dose prednisone, or 2 or 3 blasts of 60 or 80 milligrams of prednisone. I don't think anyone can argue this with me. Even if I'm wrong, they're not going to argue that I'm going to change my mind on this thought. Did I answer the question?
Yeah, and actually, I did have a patient also, we couldn't give NSAIDs because of GI leaks, so we did give steroids to the patient.
But that's how it should be done all the time, because the patients without GI bleeds are going to get them. I mean, do you know why, like, Toradol gives GI bleeds? Okay, well, Toradol's an injectable NSAID, right?
Right.
Okay, so you're under the assumption that NSAIDs cause GI bleeds because they burn a hole in the stomach, right? Well, that's not true. NSAIDs block prostaglandin, and prostaglandins maintain the lining of the stomach. So if you give Toradol IM or rectal or whatever, you're still going to give ulcers. So NSAIDs are no good for that. They're great if you have a headache and you're a young, healthy person, but they're not good for a chronically ill person with gout. So chronically ill people can be defined as those who come to the ER or come to the hospital with CHF, with diabetes, with all these problems. It's not for like the healthy 50-year-old who has nothing wrong with them otherwise except for gout. It's not, I mean, you don't want to give NSAIDs to your metabolic syndrome patients because the whole metabolic syndrome is a collection of NSAID side effects. So giving Toradol in the ER is just ridiculous. The only drug that directly burns a hole in the stomach is aspirin. And that's not going to be stopped by anything. Okay, so we're not going to use that anyway. Any other questions? I hope somebody has a question. Everyone here is comfortable treating gout? Everyone knows that colchicine is going to be on the boards for neuromyopathy? Everyone knows that allopurinol is going to be on the boards for hypersensitivity reaction and death? And you look for eosinophilia and thrombocytopenia? The crystals are parallel yellow, and that's going to be on the boards. You have any other question?
Yeah, I actually did have a.
Okay.
You mentioned like during the gouty attacks, the uric acid could be building up anywhere in the body.
It is.
Including like with cellulitis, right? So how do we differentiate? I guess it should be in our differential.
It should always be in your differential. I'm willing to bet if I spent a week in the ER here, that I'd send home 75% of the people admitted with cellulitis. I would take a needle, I'd stick it somewhere around the area, and I'd smear it, even a drop of fluid, on a slide, and I would look for crystals. Find crystals, give them steroids, send them home. Many admissions here, or anywhere, any hospital, are not necessary.
I mean,
Because when I get called for a consult on day 7 when ANSEF isn't working, they have gout.
Right. And the uric acid level's not gonna tell you.
It's irrelevant.
Right, so.
It's totally irrelevant.
You give them a blast of steroids for a couple days. Do you always taper it, or do you ever just abruptly stop it?
If it's 3 to 5 days, I may abruptly stop it. The only reason I would keep giving steroids is if this is a person who they took, let's say, 300 milligrams of allopurinol for 5 days, the uric acid's still 8.5. I have a feeling they're going to have to go up to 500 milligrams of allopurinol. I know that if I stop their steroids abruptly, I know that now they're going to be going on changing doses of allopurinol. I will be interfering with their body's steady state, and I'll be precipitating more attacks and making them worse each day. And that's another comment, is that if you have somebody who has a gout attack and you raise their allopurinol, you're going to prolong and make their attack worse. So under certain circumstances, I may simply just give them a 1 or 2 dose thing and stop, just like I may just inject the joint and kind of leave everything alone. But if it's a new patient and I know that I have to titrate things so I can get the uric acid down to a satisfactory level, I'll taper the steroid off. And if I can't taper it completely off, I'm not uncomfortable leaving them on 2, 3, 4 milligrams of prednisone. I don't think it's enough to really cause a lot of problems in anybody, and I think it's probably safer than using chronic Nsaids or chronic Colchicine. But again, for the boards, you must answer Nsaids for acute gout.